Pertussis and pertussis vaccines been something that has captivated my attention for quite a few years, and particularly since the outbreak that began in about 2009. So, it's caused by this little gram-negative bacterium. I'm a microbiologist, so I can talk about this. Bordetella pertussis, which is highly infectious. So there's this magic number called R0, which is the average number of people that a case will infect in a naive population, in a susceptible population. So for pertussis, that's estimated to be 12 to 17. For measles, it's about 18. We know measles is highly infectious. Compare that with Ebola virus, which everyone's getting excited about 1.7 to 3 at the most. So this is what we're dealing with this infection, and we think the infectious dose is probably also very low. It's a problem because, neither infection nor vaccination give long-lasting immunity. So you don't get immunity from the infection, you're pretty hard-pressed to get it from a vaccine. So people get reinfected. There's always going to be a reservoir of infection somewhere, and it's only in humans. So other infections that we deal with, like smallpox, we were able to eradicate because they were only in humans. It was only in humans, and we had a good vaccine that induced immunity. But with pertussis, we don't have a vaccine like we used to. We're used to vaccines that produce long-term immunity, and I think over probably the last 5 to 10 years we've realised, particularly with the acellular vaccine, that we're not getting that sort of protection. So we really have to think hard about what we're doing with pertussis vaccine. Susceptibility is universal in unimmunised people, and in the pre-vaccine era everybody got it by age of 5. It was one of the famous diseases of childhood, and for a long time people thought that it was only a disease of childhood. They often didn't recognise pertussis in older people. There's a secondary attack rate in households of over 90%, so you can see why really everybody got it early. The incidence is highest in the first 5 years, except where you've got really, really effective infant vaccination programs. But what we've seen is shifts to older age groups, which a few people have alluded to here. However, I'd like to just raise in your heads the thought that maybe there's a few diagnosis issues that are contributing to that picture. And diagnosis is based on a number of tests. So clinical diagnosis, those of you who work in clinical practice know the 3 phases of the illness. So there's that early non-specific catarrhal illness, then there's that classic whooping cough with the inspiratory whoop and post-tussive vomiting, and then a convalescent phase that often has a relapse of that second phase symptoms. But this classical illness, it appears, is really only in the older children, sort of infants and children up to adolescent age. So babies simply might stop breathing, and adults can just have a prolonged coughing illness. So for a long time people didn't think that adults got pertussis because they just got this cough, and adults get coughs for lots of reasons. Then there was culture, and this is a Bordet Jeanjou agar plate. It's the one that you used to use for growing, for culturing Bordetella. It has to be made up within 4 hours of use, and these days with laboratories all being centralised and often not on site, that's just not feasible anymore. And apart from that, it's a very expensive way to practice microbiology. So hardly anybody does culture anymore. There's still a few good children's hospitals who do this, and it probably doesn't matter, except if we start to have concerns about antibiotic susceptibility, we might want to get more culture specimens. But even with prompt culturing at the bedside, fresh cultures, it wasn't easy to grow this bacterium. So then serology came along. Serology is smoke and mirrors stuff. I hate to tell you, it's really very difficult to interpret and subjective for many diseases, and pertussis is one of the worst. So in early infection, often you haven't got antibodies, so it's unreliable. When you need it the most, you don't know. Anyone who's worked in a lab knows that getting that second serum for paired serum to see if you've had a seroconversion or a fourfold rise hardly ever happens. It's very unreliable in infants under 2 years of age, and they're the ones really who are the most clinically affected group that you want the diagnosis for. And in serology, it's also difficult to distinguish past infection from current infection from vaccination. So it's not very useful, it's not timely, and it's certainly not the test of choice. So now we have nucleic acid testing, which is sensitive, it's specific, it's fast, and it is the test of choice. But it can't tell infection from carriage, and one thing that has come to my attention is calls from GPs who say, oh, one child in the family had pertussis and so I swabbed all the others and they come up with positive PCRs, do I treat them or not? So we do get a certain level of asymptomatic or very mild infections that probably don't need treatment, they're probably infectious. What does that test result really mean? Because PCR testing is easy and not invasive, just a throat swab, or a nasopharyngeal swab, you get a lot more testing than you do if you have to send that little 18-month-old baby to get blood taken. Not that that's a bad thing, but it does distort our epidemiological information. Now, pertussis isn't the most preventable of the vaccine-preventable diseases, as you all know. So even though we've had this vaccine since the 1940s, it's been in our immunisation programs since the mid-50s. It is the most commonly notified vaccine preventable in Australia over the past 20 years and probably in all of the developed world. From 2006 to 12, there were epidemics in all jurisdictions and we were all using acellular vaccines, and I think I saw Stephen Lambert in the audience who will have a few things to say about that. But the average annual notification rate was more than 2.8 times that of the previous decade. In contrast, though, hospitalisation and mortality rates remained the same. So we were probably just detecting a lot more pertussis as well. There were more cases, but they weren't more serious cases. Now, if you look on our SA Health website, you'll have seen this slide because we put it up every week, and on the right-hand side it creeps out a little further. But it shows that huge big outbreak we had starting with the pandemic in 2009, and in that pandemic we got a lot more PCR testing done, and also babies with pertussis got tested. So I'm going to talk a bit faster. We certainly had a lot of pertussis cases, and I'm using data really from that outbreak period because, as you can see, it's there's not been a lot to talk about since, but what worries me is we are here. Are we going to go up again? And we must be going to. Just to show you our testing, this was back at the end of 2010, so we were getting half of our testing was from PCR, and now it's much more than that. So we're probably detecting a lot of cases that wouldn't have been detected previously simply because people will do that test. Our data from that time, South Australia was in the enviable position of having a infection rate of 448, a notification rate of 448.8 per 100,000 and per 10,000, sorry, which was many times the national average, and we were the world leaders at that stage. We had 4 deaths over the previous 20 years, but only 1 death during that huge outbreak in an infant in South Australia. So even though 1 death is 1 too many, I think it was more that we had very, very good data capture, and South Australia's got the best notification system in Australia because we have both laboratory notification and doctor notification. So we don't very, very much miss a case, whereas other states certainly do. If a doctor doesn't do the test, they never hear about it. they've only got laboratory notification. So we have very good case ascertainment. And so even though we had such a big outbreak, we didn't feel terribly guilty about what we were doing. We were under a huge amount of pressure to introduce a cocooning program, and we resisted that because our data didn't suggest that it was going to work. And this was the data that I think was the most convincing. If you looked at our childhood notifications, so these were previously vaccinated cases in children under 12 years of age. So 2,500 cases, and more than a third of them had had 5 pertussis vaccinations. This is when there was still the 18-month dose. 60% had had at least 4. 90% were fully vaccinated. They'd had 3 vaccinations. So clearly the vaccination wasn't as effective as we're used to vaccines being. It wasn't preventing infections in most people who got it. And people then began to say, well, we know with a highly vaccinated population, most of your cases will be vaccinated. No, we rejected that because we certainly don't see that with measles, we don't see that with hepatitis A, we don't see that with good vaccines. So we know pertussis vaccination doesn't prevent infection, so we could not see how it could be all that good for a cocooning program that was meant to prevent infection all around a baby. If we looked at our hospitalizations for pertussis, there was the peak in the under 1-year-old group. That second peak at the 6 to 9-year-old group, that's 5 years put together, so it's really much lower for an individual year. And what I haven't shown on this slide is that there's actually also a increase in older people, in elderly people. We get quite a lot of pertussis hospitalisations and even a few deaths in that group, but nobody cares about them as much as a baby. And particularly in adults with neuromuscular disorders, they really do badly with pertussis because they can't cough very well. But certainly the vaccine is very good at preventing severe complications. So the hospitalisation rate in children up to the age of 24 months, where we had vaccine coverage of about 92.5%, more than half of the cases occurred in the rest of the people who weren't vaccinated. So that other 7.5% was where half of our cases occurred. So we know it reduces severe infections, and that it's good for reducing hospitalisation. So cocooning, there's evidence of a number of papers have looked where babies get their infections from, and quite a few different studies. Up to 75% of infants believed to get it from a household contact, and most commonly a parent, often the mother. And the Global Pertussis Initiative during that major international outbreak thought that, notwithstanding the absence of outcome and cost-effectiveness data, if you could save just one life, it was worth doing it. It's not actually the way healthcare works, but anyway. It was proposed as a strategy to try and prevent deaths in children who are too young to be vaccinated, because it's a horrible thing to see a child with pertussis, a baby with pertussis. We wanted to minimise exposure by ensuring that nobody around the baby would be infected and therefore infectious. And so the idea was to reduce risk by vaccinating, to reduce risk by vaccinating mothers, but alternatively, in the latest handbook, the option of maternal vaccination has also appeared. The cost analysis study of cocooning eventually came out in late 2011 from Canada, and the conclusions were that the immunisation of new parents with pertussis vaccine is expensive and resource intensive. Number needed to vaccinate was 10,000 to prevent a hospitalisation, 100,000 cases, this is people to vaccinate, to prevent one infant intensive care admission, and more than 1 million to prevent one infant death. Now, when you factor in that the vaccine is sort of $35 to $50, that's $35 to $50 million to prevent one infant death. it doesn't get past PBAC, I can assure you. So that's why it was never funded nationally, even though that information wasn't around. People knew it was going to be very expensive. But even if it was favourable, it just doesn't happen. You just cannot implement that program well, and particularly it's really hard to get anyone but the mother vaccinated, and particularly fathers. So maternal vaccination was then proposed, and it has now been recommended in a number of countries. And we were assisted with getting some evidence about this by a large outbreak in Britain, which was published in Lancet earlier this year by Dr. Emma Thallingham from the Public Health Agency and her group. So the UK had this large outbreak, which was declared back in, can't see that, I think it was about April in 2011, and this is October 2011. At that stage they decided to fund maternal vaccine for women in the 3rd trimester of pregnancy. So this was great, we got some data. It was also motivated by the fact that they had 14 deaths in infants under a year of age in they had 6 deaths in 2011, and then there were even more deaths in the following years. So they funded that program and got a lot of data which we could look at. Now, their cases showed clearly that it's the babies who haven't had 3 doses of vaccine who are the ones getting the highest burden of disease, and we know that they're also the ones who have the poorest prognosis. So they studied nearly 27,000 women who had a live birth in that program, which commenced in October 2012, which was also when the epidemic peaked, but that's the way it happens. Still got some good data. And for the first 9 months, they saw the greatest proportionate fall in cases, this is in under 3-month-old children, a 78% reduction in cases and a 68% reduction in hospitalizations in those babies whose mothers had been vaccinated in the 3rd trimester of pregnancy, which is dramatic. And this under 3-month age group was also the only age group in which there were fewer cases in that year than in the previous year. So it was actually definitely reducing the number of infections. And this was with only about 64% average vaccine coverage, so not even the sort of 90%, 100% that you'd be hoping for. And somebody's mentioned earlier, the effectiveness in infants was around 90%, 91% if you just looked at under 3 months, and 90% if you looked at children under 2 months. That's 90% is a very good effectiveness for a vaccine. And they also found that the vast majority of mothers were in favour of this. So it's really only the orange and red ones who were probably resistant to pertussis, and they probably haven't seen a baby with pertussis, but they might have changed their minds. So other important considerations, and I think someone's mentioned this too, vaccine safety. Of course, you worry about vaccinating pregnant women. They didn't identify any vaccine safety issues, though they are still gathering data on that. And the other comment about the possibility of it blunting antibody responses to other vaccines that are given in that infant age. So far, they haven't seen any relative increase in cases of those other vaccine preventable diseases, which suggests that it's not having a significant, a clinically significant effect on the immune response, even though it might give a measurable antibody change. But they are continuing to follow that up. So maternal vaccination is the only way that you can protect infants from the time of birth, because you have to get the antibodies into the baby. It's not actually that useful to get the antibodies into somebody else if it's not preventing infection and infectiousness. And you have to get the babies through the period when they're at the highest risk of death and severe complications. And severe complications we're talking about with pertussis are hypoxic brain damage, epilepsy, intellectual deficit, brain hemorrhage, retinal hemorrhage, hernias. So they're not trivial complications. The vaccination in the 3rd trimester gave the best transplacental transfer of antibody. There's been other studies that have looked at antibody, cord antibody levels from before immunisation, before pregnancy, and they're not really at protective levels. So this is the best way to get as much antibody as possible into that baby, and it gives that protection until they start getting their vaccines. And of course there's the added benefit of a cocooning effect, where these women are not likely to be a source of infection for their babies or other children. So it's recommended in the UK, USA, Canada, New Zealand and Belgium in every pregnancy, to answer the question someone got before. But that's for an outbreak measure. Whether it will still be recommended when there isn't an outbreak in all of those countries, I'm not sure. And it would be good for a recommendation for it in every pregnancy if we had a single antigen vaccine, because people are going to get pretty sore arms with all that tetanus antigen. But that's the current recommendation. It's also, there isn't a single antigen vaccine on the market, and I'm kind of hoping that if enough countries are recommending maternal vaccination, that there might be interest in vaccine manufacturers to work on that, and they may be. They're coy about things like this. So that's my discussion about this, and I apologise if I didn't give as much detail to that. I was originally asked to talk about cocooning, but I said I wouldn't talk about cocooning unless I could talk about maternal vaccination as well. So thank you.
Hi, my name is Kate. I'm currently a pregnant immuniser. So I guess my question is particularly pertinent for the fact, even of myself, I myself had a boosterix back in April, May of this year, and now obviously talking about maternal immunisation. Is it still, I guess, considered safe for me to have another one in my 3rd trimester?
I doubt anybody would be recommending that. I'm sure it's safe, but it's a grey area, and I certainly wouldn't be recommending that you had another one so soon.
Hi, my name's Kate too, and similar question. If I've got a very well-informed mother who has no objections to sore arms and no objections to paying lots of money, do I tell her that the official recommendation is that she has a pertussis immunisation with every pregnancy?
Yes.
She's very well informed and she's Googled. Yes.
Well, it's I can't say what's going to be in the official ATAGI recommendations, but certainly you would be recommending vaccination in the 3rd trimester. ATAGI's met recently, and we're going to discuss the stage at which it's given, which weeks, and I wasn't able to get to that meeting because of Ebola, but I don't know if someone can comment on that. Yeah.
Ross Andrews from Menzies School of Health Research, and chair of ATAGI. The process is that the handbook is an NHMRC endorsed guideline, and so to make changes to the handbook, if there are major changes, then it goes through a public consultation phase. So concepts about, so as of right now, there is no recommendation from ATAGI that you should get pertussis vaccination every pregnancy. But what that is the recommendation in the UK, that there'll be a public advertising of the recommended changes to the handbook, which includes pertussis and other changes to other major components, which invites community consultation in that over a month, and it does slow the process down, but it is a very important part of development of guidelines involving the NHMRC, because it puts the recommendation out, exposes it to criticism and comment, and there are always lots of comments, and that's intended to try to make the handbook a more usable document. So short answer is, right at the moment, there isn't a recommendation to get pertussis vaccination every pregnancy. but that is the case in the UK. There is some data for the person who was vaccinated recently. There is some data that suggests if you're vaccinated within 13 months of your pregnancy that there is good antibody transfer still through the placenta. Whether that is sufficient to relate to less disease, that's a different question. Sorry,
just a quick question. Third trimester is fairly broad. When exactly does it matter?
That's has to be sort of specified in the handbook. I think it's usually about 26, 28 to 32 weeks, but actually in the British study there was one death in an infant whose mother had been vaccinated, and that vaccination had occurred a week just prior to delivery. So we want to get, you would want to get the vaccination early enough in the pregnancy to allow for premature deliveries so that the baby would still be protected and to give time for a maximum response. But timing is a bit difficult.
With healthcare worker vaccination policy, it's recommended for healthcare workers to have the Pertussis vaccine. Have we got funding for that?
Funding for healthcare workers is an employer responsibility. It's an occupational health and safety issue. So it's not funded by the immunisation program, and it's not state funded, except, you know, for state funded hospitals.
Well, that's what I'm asking about.
Yeah, it's an OH&S issue.
So have we got funding though for state funded hospitals for healthcare workers to be vaccinated?
Hospitals have budgets. They have to allocate the budget, yeah. Just like they have to allocate a budget for personal protective equipment, training, etc.
Worker health comes under the Department of Health at the moment. It's not coming under individual hospitals.
No, it does go under individual hospitals as well. Certainly does.
Last question.
Therese from Pickaway Health Service in Port Augusta. We promote immunisation with the flu needle for pregnant women. Just wondering, is there a recommendation, or if we're doing the boostrix as well, would we be doing it both in the third trimester, or because we vaccinate for the flu throughout pregnancy?
Yeah, I would not be delaying the flu vaccination until the third trimester, because women don't wait till the third trimester to run into problems with that. So they might need to have two